Welcome everyone to the Orlando GI Journal Club for July. Our first study in the Journal Club is looking at the impact of artificial intelligence on miss rate of colorectal neoplasia. This was published in Gastroenterology. The miss rate of colorectal neoplasia remains the most important cause of post-colonoscopy colorectal cancer, with a 10-year incidence of 1%. Up to 57% of these post-colonoscopy colon cancer cases may be due to missed neoplastic lesions during index colonoscopy. And the miss rate of colorectal neoplasia after screening colonoscopy has been reported of up to 25%. In previous randomized trials, artificial intelligence has been shown to increase the adenoma detection rate. However, endoscopists with high adenoma detection rate can still be affected by adenoma miss rate, which may be responsible for interval missed colorectal cancers. So the aim of this randomized trial was to investigate the possible reduction of adenoma miss rate of colorectal neoplasia using artificial intelligence, specifically the GI Genius software by Medtronic. This was a randomized trial from 8 centers in 3 countries, the US, United Kingdom, and Italy. Patients aged at least 45 years who are at average risk for colon cancer were undergoing screening or surveillance colonoscopies. Patients were randomized in a 1-to-1 fashion to 2 arms, and they went 2 colonoscopies on the same day, back to back. And in group 1, patients underwent colonoscopy using AI first, and then it was followed by a standard white light colonoscopy without AI. In the second group, the patients underwent standard colonoscopy, followed by a white light colonoscopy with AR, and the GI Genius and artificial intelligence system was used. The primary endpoint was to look at the rate of the adenomas missed. And the adenoma miss rate, or AMR, was calculated by looking at the number of histologically confirmed adenomas and cancers at the second colonoscopy, divided by the total number of histologically confirmed adenomas and carcinomas detected during both colonoscopies. So when they looked at the adenoma miss rate, the authors enrolled 230 patients, 116 patients in the AI first group, 114 patients in the standard colonoscopy group. The overall adenoma miss rate was significantly lower in the AI first group at 15.45% versus 32.4%, with odds ratio of 0.38 and p-value of less than 0.001. When they performed a subgroup analysis looking at the sizes of the adenomas missed, they found that the really small adenomas measuring 5 millimeters or less was significantly lower in the AI group at 15.9% versus 35.8% in the standard colonoscopy first group. This also held true for adenomas less than 10 millimeters, with significantly lower adenoma miss rate in the AI first group at 16.5 versus 33.8% in the standard colonoscopy group. They found that the adenoma miss rate was significantly lower in the AI first group compared to standard group in both the proximal colon and the distal colon. And they found also, when looking at the different types of polyps that were missed, that the adenoma miss rate was significantly lower for just conventional adenomas, but there was no difference between the 2 groups when looking at carcinomas, sessile striated lesions, or hyperplastic polyps in the proximal colon. Then they looked at the detection rate of adenomas and polyps during the second colonoscopy, and they found that the detection rate of polyps during the second colonoscopy was significantly lower in the AI first group in subjects with at least 1 colorectal polyp seen in the second colonoscopy, subjects with at least 1 adenoma cancer seen in the second colonoscopy, and also subjects with at least 1 adenoma cancer in the second colonoscopy in patients who had a negative first colonoscopy. this last result is particularly important because what they're saying is that in patients who had no colon polyps in the first colonoscopy, when they did a second colonoscopy, they were able to find at least one adenoma or a carcinoma. And this rate was only 6.8% in the AI group, but 29.6% in the standard colonoscopy group. The limitations of this randomized trial is that they included endoscopists with moderate adenoma detection rate only. Most of the reduction in adenoma miss rate with AI was due to polyps less than 10 millimeter in size, which are unlikely to progress to invasive cancer in a short period of time, and therefore larger studies are needed to assess possible decreases of miss rate for advanced adenomas. This was a tandem study design rather than parallel arm design, which tends to give positive results when validating the same device by the same operator, possibly due to psychological bias. The take-home point is that artificial intelligence resulted in an approximately twofold reduction in miss rate of colorectal neoplasia, supporting the benefit of artificial intelligence in reducing errors for small and subtle lesions during standard colonoscopy. This is a second study looking at the clinical outcomes on weekly endoscopic dilation as the initial approach to managing patients with complex benign esophageal strictures. The study is important in clinical practice because the success rate of endoscopic dilation of complex benign esophageal strictures can be low and has been reported to be as low as 60 to 65%. And the usual standard therapy is to perform dilations every 2 to 4 weeks. So the aim of this study was to evaluate the clinical outcomes when performing esophageal dilations at weekly intervals in patients with complex benign esophageal strictures. This was data analysis from a prospectively maintained database looking at patients with benign esophageal strictures that were defined as being complex because they were either long, more than 2 centimeters in length, tight, less than 10 millimeter in diameter, tortuous, or multifocal. They had a median follow-up period of 4 years. And the primary outcome was to look at the successful dilation achieved with weekly dilation strategy. And they defined successful dilation as achieving a dilation diameter of at least 14 millimeters, and the patient was dysphagia-free, and the patient underwent no more than 1 dilation every 3 months to maintain the diameter or remain dysphagia-free. So this was the strategy of weekly dilation that the authors used. They performed dilation every week until lumen diameter of at least 14 millimeter was achieved and the patient had no symptom of dysphagia. And then to maintain the lumen diameter of at least 14 millimeters at each weekly dilation, the extent of luminal regression was assessed based on which frequency of follow-up dilation, and they increased from weekly to once every 2, 4, 6 weeks. Or reverted to more frequent dilation. So they based kind of the follow-up dilation interval based on the degree of luminal regression. When the patient was deemed to be successfully dilated, they performed a dilation every 3 months or more. And in patients in whom the lumen diameter of more than 14 millimeters were able to be achieved, for patients with short shelf-like stricture, they used needle knife incision, and for long strictures, a covered esophageal stent was performed. So a total of 57 patients were analyzed in this study. They categorized the patients into 2 different groups. Group A had prior esophageal dilation performed every 2 weeks or so, but had failed. And second group, Group B, had no prior dilations. And these are the etiology of the strictures in patients in both groups. As you can see, there was no difference between the 2 groups. The most common causes were due to peptic stricture, radiation therapy, anastomotic stricture, corrosive injury, and a small proportion of patients with post-EML RFA strictures and Schatzki's. when they looked at the long-term treatment success. So again, it's achieving lumen diameter of at least 14 millimeters and patients remaining dysphagia-free. In group A, so patients who had dilation attempts before but failed, success was achieved in 57%, and treatment success of 83.3% was achieved in patients who had never undergone dilation before but nevertheless had had complex benign esophageal stricture. When you're looking at patients who needed further therapy, 5 patients in group A and 4 patients in group B needed metal stent placement, and 1 patient in group B needed needle knife incision with placement of a metal stent. 2 adverse events were seen in total, perforation in 1 patient and bleeding in 1. These are the limitations of the study. Only 57 patients included in the study, so the numbers are relatively small. There was no cost analysis performed, which may be a significant factor, especially in patients without insurance or self-paying, and also this was a single center study. The take-home point from this study is that 57% of patients with complex benign strictures who failed prior dilations and 83% of patients with complex benign esophageal strictures without prior treatment achieved dysphagia-free status with weekly dilation strategy. Therefore, this weekly dilation strategy should be considered prior to considering more complex options such as use of needle knife incision and esophageal stent placement. Next is a study by Che et al. It's a randomized trial looking at vonopressin triple and vonopressin dual therapy for H. pylori infection in the United States and Europe. This is a randomized clinical trial. The study is important because H. pylori is a leading cause of peptic ulcer disease, gastric cancer, and gastric mucosa-associated lymphoid tissue lymphoma. And guidelines recommend H. pylori eradication whenever identified. For several decades, eradication therapy has been dominated by PPI-based therapy, comprising PPI with clarithromycin and amoxicillin or metronidazole. However, treatment success with PPI-based triple therapy is falling due to clarithromycin resistance. Vonopressin is a potassium-competitive acid blocker and is freely used in East Asian countries, especially Japan. And the studies which have been limited to East Asian countries have shown higher eradication rates than PPI-based triple therapy. The aim of this phase 3 clinical trial in US and Europe was to compare the efficacy and adverse events of vonopressin triple therapy and vonopressin dual therapy versus PPI-based triple therapy for H. pylori eradication. So this was a phase 3 randomized trial. It was a multi-center study from the United States and Europe. This was a non-inferiority trial with non-inferiority margin set at 10%. They looked at treatment-naive patients with H. pylori infection and were randomized into one of the 3 groups into 1:1:1 randomization ratio. Patients were given either vonopressin dual therapy, which is vonopressin plus amoxicillin, vonopressin triple therapy, which is vonopressin plus amoxicillin plus clarithromycin, and the third group was PPI triple therapy, lansoprazole with amoxicillin and clarithromycin. The primary outcome was to look at H. pylori eradication rates in patients without clarithromycin and amoxicillin resistant strains determined by breath test at 4 weeks post-treatment. These are the baseline characteristics. 324 patients were randomized to the vonopressin dual therapy, 338 patients to the vonopressin triple therapy, and 330 patients to the lansoprazole triple therapy. And as you can see, the most common symptom that the patients had was dyspepsia, accounting for more than 96% of all cases. in all the groups. And in terms of antibiotic resistance, the most common antibiotic resistance was to metronidazole, followed by clarithromycin and then amoxicillin. So this is the results. So this is a bar graph looking at H. pylori eradication in all patients. And as you can see, the eradication rate for vonoprozan dual therapy was 77% versus 80% for vonoprozan triple therapy and 68.5% for lansoprazole triple therapy. When comparing the eradication rate of the vonoprozan dual therapy to lansoprazole triple therapy and vonoprozan triple therapy to lansoprazole triple therapy, the rates of eradication was significantly higher for both vonoprozan dual therapy and vonoprozan triple therapy compared to the traditional PPI triple therapy. When looking at H. pylori eradication in patients with non-resistant strains, again, the rate of eradication in the vonoprozan dual therapy was 78.5% compared to 84.7% in the vonoprozan triple therapy and 78.8% in the lansoprazole triple therapy. When comparing the eradication rate of in non-resistant strains of vonoprozan dual therapy and triple therapy, compared to lansoprazole triple therapy, they found that the triple therapy eradication rate was significantly higher compared to the lansoprazole triple therapy, with p-value of less than 0.001. This is H. pylori eradication rates in patients with known clarithromycin-resistant strains. And as you can see, again, in patients with known clarithromycin-resistant strains, the eradication rates were highest in the dual therapy and triple therapy using vonoprozan at 69.6% and 65.8% respectively. And in the lansoprazole triple therapy group, the eradication rate was only 31.9%. These are the adverse events. None of these serious adverse events were attributed to treatment to H. pylori eradication treatment. And the most common adverse events that were encountered included upper abdominal pain, patients who had COVID infections, diarrhea, nausea, headaches, hypertension, vomiting, and nasopharyngitis. These are the limitations of the study. They included treatment-naive patients only, and therefore we are unable to generalize the results of this study to patients who have been previously treated. 103 centers participated in the study in total, with many centers contributing only a small number of patients in this study. The take-home point from this randomized trial is that among patients from the United States and Europe, when compared to lansoprazole-based triple therapy, vonoprozan-based triple and dual regimes were non-inferior for eradication of H. pylori strains not resistant to clarithromycin, superior for eradication in patients with clarithromycin-resistant strains, and also was superior in all patients when looking at strains with no resistance and resistance to clarithromycin. Our final study is a meta-analysis by Zweger et al. Published in Gastroenterology. And this is a meta-analysis looking at deep submucosal invasion as a risk factor for lymph node metastasis in T1 colorectal cancer. The study is important because risk of lymph node metastasis in T1 colorectal cancer have been reported in 1 to 34% and depends on the presence of histological risk factors. Deep submucosal invasion identified as invasion of at least 1,000 micrometers or SM223, poor differentiation, lymphovascular invasion, and high-grade tumor budding. The presence of one or more of these risk factors categorizes the patient as a high-risk patient, and this then precipitates oncological surgery with mesocolic lymphadenectomy. However, more than 90% of these patients end up lymph node negative on histological evaluation of the surgical specimen. Currently, deep submucosal invasion is the most prevalent criteria for refraining from endoscopic resection or for referring to additional surgery, but studies have shown conflicting results on the predictive value of deep submucosal invasion and may be only a weak predictor for lymph node metastasis in the absence of the other risk factors, such as poor differentiation, lymphovascular invasion, and tumor budding. So the aim of this meta-analysis was to evaluate deep submucosal invasion as an independent risk factor for lymph node metastasis in patients with T1 colorectal cancer. This was a meta-analysis comprising 67 studies and over 21,000 patients. They included studies reporting on the association between lymph node metastasis and histological risk factors in patients with T1 colorectal cancer treated with endoscopic resection or surgery over a 21-year period. Then, out of the 67 patients, they identified 8 studies to include in the multivariable analysis, and this comprised 3,621 patients. So when these authors performed a univariate analysis, just looking at all the possible variables in itself, just as an isolated variable, they found that the overall rate of lymph node metastasis in patients with T1 colorectal cancer was 11.2%. Deep submucosal invasion on univariate analysis was associated with lymph node metastasis with odds ratio of 2.58. However, this is when it gets very interesting. When they performed a multivariable analysis, they found that the odds ratio for deep submucosal invasion was 1.73 with a 95% confidence interval of 0.96 to 3.1. And because the 95% confidence interval crosses 1, this shows that deep submucosal invasion is not significantly associated with lymph node metastasis. When they looked at the other high-risk factors for lymph node metastasis, such as lymphovascular invasion, poor differentiation, and tumor budding, they found that all these factors were associated with lymph node metastasis. So for lymphovascular invasion, the odds ratio for being associated with lymph node metastasis is 3.16. For poor differentiation is 2.14. For tumor budding is 2.8. The main limitation of this study is that this is a meta-analysis, and this means that you're relying on the quality of other studies that you have not conducted on your own to determine the quality of this meta-analysis. So meta-analysis is the literal research and statistical translation of you get out what you put in. So unfortunately with this study, I think the advantage is that they were able to find so many studies conducted over the last 21 years looking at this important issue. So 67 studies in total, but the majority of these studies were retrospective. And as you know, individual retrospective studies have severe and several limiting factors. And therefore, I think this is kind of the major disadvantage of this meta-analysis. Other limitations are histological pathology may not have been assessed uniformly between endoscopically resected and surgically resected specimens. And the authors were unable to look at the impact of other factors such as tumor location on the risk of lymph node metastasis. So the take-home point from this meta-analysis is that there was no significant independent association between deep submucosal invasion and lymph node metastasis. And so this essentially challenges the traditional dogma of deep submucosal invasion as being a strong indicator for oncological surgery and active surveillance. Instead of radical surgery for deep submucosal invasion in T1 cancers, as the sole risk factor, therefore may be a reasonable approach considering the low risk for lymph node metastasis. So in summary, artificial intelligence resulted in an approximately twofold reduction in missed rate of colorectal neoplasia, supporting the benefit of artificial intelligence in reducing errors for small and subtle lesions at standard colonoscopy. 57% of patients with complex benign strictures who failed prior dilations and 83% of patients with complex benign strictures without prior treatment achieved dysphagia-free status with weekly dilation strategy. Therefore, a weekly dilation strategy should be considered prior to considering more complex options such as needle knife incisions and use of esophageal stents. Among patients from the United States and Europe, when compared to PPI-based triple therapy, vonoprazan-based triple and dual regime were non-inferior for eradication of H. pylori strains not resistant to clarithromycin, superior for eradication in clarithromycin-resistant strains, and superior overall in all patients. In the meta-analysis, looking at submucosal invasion and lymph node metastasis, there was no significant independent association between deep submucosal invasion and lymph node metastasis in patients with T1 colorectal cancer. This challenges the traditional dogma of deep submucosal invasion as a strong indicator for oncological surgery and active surveillance rather than radical surgery in patients with known deep submucosal invasion as a sole risk factor, therefore may be a reasonable approach considering the low risk for lymph node metastasis. Thank you very much. Our next journal club is on August 3rd, which is the first Wednesday of August. I hope everyone has a wonderful July, and thank you so much for joining us this month. Thank you.